Dr. Helen Zealley has been a fellow of this college since 1987. In 1988, she was appointed as Chief Administrative Medical Officer of the Lothian Health Board. In 1991, she became the Executive Director of the Lothian Health Board, and she was in that appointment until she retired. Dr. Zealley, you were born in 1940, so that probably means that your experience and your memories of medicine really are very much of the National Health Service and very little before that. Is that the case?
I've got a vague recollection of having a JAG in 1946, I think it was, and so that must have been some immunisation I was given at the time. And I also have a memory, I know it's 1946 because that was when we moved from Edinburgh to London, of stopping by in Manchester with my grandmother's university friend, and she was a paediatrician, and we were going to go and see 4 tiny babies that had all been born at the same time, obviously quads. And I was heartbroken because I wasn't actually allowed to go in and see them because I was a 6-year-old. Children weren't allowed into maternity units at the time, but my parents went in to see these miracle babies. So that's my first recollection of health services, but certainly the NHS has been most of my life.
But that immediately leads into something of interest. You were born to what was very much a medical family then.
Yes, yes. Both my parents were doctors. My mother's still alive, but she didn't practice after she was married. And before that, my father's mother was a doctor as well. Again, she didn't practice after she was married, but she was engaged for 10 years so that she could practice before she got married.
But then I think that she had experience of, shall we say, state services as well. Didn't she have duties in the poor law medical service?
Yes. I mean, obviously in 1901, when she graduated, it wasn't very usual for women to be practicing medicine at all, anywhere. There were only 6 in the class she was in, and it wasn't even at the university. They weren't allowed to be at the university. It was a sort of separate place. And I presume that the openings for women at that time were very limited. She did a stint in Dublin. She did a stint in, I think, somewhere else in Ireland. And then she came and worked in Craigleith Poorhouse, which is, of course, now the Western General. And she was there as the doctor. She had a hospital section of 60 beds, and she also had to look after the well-being of the 200 or so inmates in the poor law part of the Western.
Yes, I've read about that, and that must have been a fairly intimidating experience, was it not? Not enough to give you a rather sort of forbidding view of what medical practice was going to be.
Yes.
To have your grandmother with that appalling load of clinical load.
She never talked about it as an appalling load. I mean, I found out subsequently from her when I was older, and from what she's written. And interestingly, her references for her next job were printed. She had a printed copy of her references, and it explained what she had done, the surgery she'd done, the post-mortem she had done, the whole shooting match she'd had to do.
So I think inevitably this background, the family background, must have impinged on you and to some extent at least determined what you were going to do as a...
Interestingly, yes, I suspect my grandmother's public health component, because she then went on and in Manchester she worked in a public health, under the public health service as well. I think her interest and commitment to particularly children in deprived circumstances, she used to take me around what were called toddlers' playgrounds. Mm-hmm. They're now called children's centres, where disadvantaged families' children are looked after. And I mean, I remember being taken around there from being a tiny tot with her, and she was absolutely committed to services, not just health services, but support services for disadvantaged children. And that certainly had an influence on me.
And would it be then a total family experience? And was it particularly your grandmother? Or how about your father? He must, presumably in his career, must have had some influence.
Yes, I think she probably did influence him as well. He was the youngest son. His older brother had to go into the family law firm, so he was actually free to choose. And I think he will have been influenced both by his mother and by her brother, who was a GP in Stockport, and again working in a fairly deprived area.
And did you have brothers and sisters?
Yes, I've got 2 brothers and a sister, and one's a sculptor, one's an accountant, and one is, oh, she's become an accountant as well.
But
I'm the only doctor.
You have kept the family tradition going,
Yes,
but
yes.
only you.
Only me. But I've also married a doctor,
Yeah.
and both my children are doctors.
And then you went to school at St Albans.
Yes, when we'd moved down, well, first of all, I was at school in London.
Right.
The rest of my primary schooling was in London, and my secondary school was all in St Albans, because we moved out to Hertfordshire.
So you didn't have experience of schooling both in England and Scotland then?
No, all my siblings did, because they were younger. We moved back when I was 15, and I stayed at school in St Albans to finish off. But the others were all younger, so they did their secondary schooling up here.
Was that something that gave you cause to think later of having been at school in England? Was it of any significance at all, really?
Well, I regret not spending my childhood in Scotland, yes. Because it makes me not sound Scottish. That's a fairly major thing. Everybody thinks I'm English, and I don't like that.
Tell me, at school, presumably you were already thinking of medicine, even then?
Yes. I think that the absolute turning point was reading A.J. Cronin's The Citadel. I mean, that was my absolute...
And what age would you be then, do you think, roughly?
About 12 or 13, I think, yeah.
Right. What was the attitude then of your school towards your ideas towards medicine?
Oh, they were very pleased.
Yeah.
It was a girls' school, all girls. Not all that many of us from the 6th year, probably about 10 out of 30 or something would go on to university, but they certainly liked people going on to university. There were boards, boards with people's names up if they went to university and their degrees. And to go and do medicine they definitely liked that.
So the input in that sense from your school was entirely positive?
Encouraging, yes. Yeah.
And then you decided to go to study medicine in Edinburgh?
Yes.
Or was that an inevitable choice?
No, it wasn't. At the time, my father was the dean. So in fact it was actually a relatively uncomfortable choice. But looking back, I mean, it seems silly to say this, but because he was employed by university, I didn't have to pay any fees. And they were paying out 3 lots of school fees for my siblings at the time. And I think the family finances were fairly stretched, and I thought it was something I could do to help with things.
And what do you think about it now, looking back on having spent these years in Edinburgh? Were they happy years or difficult?
Yes. Well, being the dean's daughter wasn't the easiest of roles at university. I mean, it took a while for me to make my own friends, and that was okay. Then he became my father rather than me being his daughter, if you understand the sort of subtle change. But no, they were good years. I mean, university is good, isn't it? It's an exciting time. You're learning new things. You're meeting interesting people. We had some super teachers. I was in the last clinic of Derek Dunlop's clinic in the Royal. Ray Gilchrist. Some quite big people were our teachers, and that was good.
were there any who had a particular influence on you? These were very eminent people, but how about you personally? Did any of them pinch particularly on you and your
Derek
ideas?
in particular.
Sorry?
Yeah, Derek in particular.
Derek.
I mean, as I say, I was in his relatively small clinic in my first clinical term, and it happened to be his last teaching term. So I suppose we knew he would be going, and maybe we absorbed it all the more. I do remember Ray Gilchrist. He was terrifying, but JDS Cameron, John Bruce, Robert Keller. I mean, they're all big names, and Edinburgh was at one of its peaks. It seems it has peaks and troughs, doesn't it, Edinburgh? And it was a good time.
It's interesting, you've picked out entirely clinicians. Other people have thought that some of the preclinical ones, but these were not particularly important.
I have to say, anatomy wasn't my favourite subject. Gordon Whitteridge was pretty scary in physiology. Walter Perry, science, I'm not a brilliant scientist, I have to say. Maybe the scientific side wasn't what caught me.
And looking back on these long years as a medical student, what do you think now about the balance of the thing? Because that has changed, hasn't it?
Yes, enormously.
Now, do you think this shift on the balance has been a positive move then?
Yes.
From your years?
Yes. I mean, I really think 5 terms, laboriously, tediously, looking for cutaneous nerves is not a particularly useful education. You grow up, you learn lots of other things during the process, but just watching our children at medical school, one of whom was in Edinburgh and one was in Dundee, they had rather different teaching programs. They both graduated in 91, so that was sort of through the late 80s. So it wasn't quite as it is now, but it had certainly changed from our time. And the focus on interaction with patients, communication, learning to connect the bits of information, sort of getting a whole picture rather than a bit of anatomy, a bit of physiology, a bit of biochemistry, a bit of pharmacology, as we had. I think they've ended up better doctors as a result.
And then during that time, as a medical student, did you already have the career that you eventually came to? Did you have that in mind, or was it still an open?
Absolutely not.
Right.
I think, I don't know whether I actually ever explicitly said it, but I was quite clear I was not going to do public health, because the public health at the time I was a medical student was different than it became. I actually, if I could have absolutely chosen, I would have chosen paediatrics or paediatric psychiatry, something with children. But I got married when I was a houseman, and it was a transition time for women, once they'd had children, to work. Most women with preschool children stopped working at that time, and the doctors who stopped would tend to go back to do family planning or school doctoring or that sort of thing. And I suppose I assumed I might have that sort of career. I wasn't career orientated at all. Absolutely not. Absolutely not. But I went and did some microbiology and particularly virology, and got involved with specialising in the virology for the Children's Hospital. So I got my bit of paediatrics there, which I enjoyed. And then it became clear that the specialty of virology, I did an MD and, sort of began to get interested. And I had 2 little preschool children by that stage. And I was intending to stop, but the person who was running the virology lab at the time left, Margaret Moffat. She left and went to Aberdeen, and they were actually going to have to close the City Hospital virology lab because she had gone and I was going. So I said that I would stay, but I would prefer to be half-time. And Winnie Thompson, who had covered my work while I was on maternity leave, said she would come and do the other half. So we inadvertently job sharing for women doctors. So it meant the lab stayed open, we were both able to work with our little children. And then the lab sort of came back to life again, and then Betty Edmond came, and after that Alistair McCrae, and it sustained and remains a very good virology lab. But we just helped to see it through a 2 or 3 year period when it might have disappeared. And doing virology at that particular time in the late 60s, early 70s, you either became a biochemist, the sort of cellular biology side of viruses, or you went up the way and looked at what viruses did to populations of people, epidemiology. And I was far more interested in the epidemiology, doing vaccine trials and spread of infection and things like that. So I went for the epidemiology, and at the same time, a new specialty called community medicine was emerging. It was about 1972, I think, 71, 72. A new specialty of community medicine was emerging from the old public health service, the hospital administrative service, and the academic epidemiology and social medicine components. And it sounded good. It sounded as though, obviously what was being written about it was that it was going to be terribly important in the restructured health service, the 1974 restructured health service. And my idea was to continue my interest in infectious disease, particularly in children, in this new capacity as a community medicine specialist. So I then transferred and came through a formal postgraduate training program for that, which involved going back to university to do a master's in social medicine, and then doing what was then the new Faculty of Community Medicine exams. Did that. And during the training, realised that this new specialty was an amazing one. It was so broad. Against my expectation, I found the old style public health interesting, the historical perspective, and then what it was leading on to at that time. And administrative medicine, in terms of planning services, planning changes to services to meet the new and changing needs of the healthcare, was much more interesting than I expected. So I actually didn't go off to do infectious disease epidemiology. I stayed in the more general mainstream of the new specialty.
But by that time you did have an MD.
Yes.
What did you what's your thesis on?
It was on Q fever antibodies in Edinburgh children, which we found as a completely unexpected finding, subsidiary finding of a study of respiratory infections in children. And there was something like 20% of the children had antibody to Q fever for no apparent reason. They hadn't ever been symptomatic. And well, the sort of long and the short of it was, we also tracked that cattle and sheep in the Lothians were infected, quite high levels of infection. And the epidemiology of it was that the children tended to seroconvert at around the age of 5 or 6 months. And the hypothesis was that they were getting an infection in pasteurised milk, so they were sort of semi-immunising themselves. But then it went away again. So it's never been there've been sporadic clinical cases, or there were being sporadic clinical cases at that time, but there was never any epidemic of it.
So were you thinking of your sort of, if you like, academic background before going on with you had an MD, and after your MD, your membership?
For here?
Yeah. You didn't?
I didn't.
Right.
I was scared to do it. My husband had failed it the first time, and I thought, golly, if he failed it, I'm bound to fail it. So I didn't do it.
Right.
Actually, I hadn't probably done sufficient postgraduate clinical medicine, because I went off after my house jobs and did this virology. So I wouldn't really have had sufficient, not that you had to have the time, but I probably wouldn't have had sufficient clinical experience at the time. And I wasn't seeking to have a career. The MD emerged because I had this interesting finding that I pursued, and so I wrote it up.
But I think you mentioned a master's degree, didn't you?
Yes, I did a master's, that was in public, well, it was called social medicine at the time.
Right.
And then I did the membership of the, what was it called at the time, Faculty of Community Medicine.
Right.
And subsequently I was honoured to be made a fellow here.
Right. So, but you had these things behind you before you launched onto the public health?
Well, yes, I mean the membership of the Faculty of Community Medicine was the entry qualification, well, the legitimacy for becoming appointed as a consultant in that specialty. So that's what I did. Yeah.
Right, and when you moved from virology, then your public health interest, as far as I can discover, was pretty well directed at children's services.
Yes, yes. In the very first consultant job I had was medical manpower, sort of doing manpower planning for numbers of senior registrars, training programs for surgeons, training programs for GPs, introducing junior doctors' hours of work, some fairly horrendous, if you like, boring administrative.
And who were you doing that for? Was that
at Lothian Health Board?
The Lothian Health Board.
Yes, but it was very, very interesting in a way, because I got to know all about every single specialty, the ins and outs, the training programs for all of them, which consultants were getting cross with which other consultants, who had subspecialty interests in what. I learned an enormous amount about health services in Lothian doing that job.
Which must have been useful later.
Which stood me in very good stead. And I became actually sort of quite a source of knowledge for a lot of people, because I just knew that side of what was going on. So in terms of health service planning, which we were doing a lot of at the time, you know, there was all the sort of restructuring that has ended up with the shape of service that we've got now, with the two big hospitals, well, there's 3 hospitals, including St John's, and, if you like, sadly, the loss of all the smaller hospitals. But that was being planned in that period in the 70s. It's taken 20 years to implement it all.
So how long did you spend on
that job?
on that part of it?
I was about 8 years, I think, doing that.
Incredible.
Yes. Yeah.
So I had thought you had come back to children's.
Oh no, maybe it was less than that. Maybe it was 5 years. I think it was 73 to 78 or something. And then the consultant who had been overseeing the children's services, Jean Willison, who had come from the public health, the Edinburgh Public Health Department, she retired, so there was a vacancy there, and I applied for that and moved into that. And I had 10 years working with the children's service, and that was good. That I suppose was my happiest.
Debbie, what do you think was the state of these children's services at that time? And perhaps I should explain why I ask. Because there was a comment earlier by the president of this college, Sir Charles McNeill.
Yes.
Because in 1950 he said very damningly that our best men and women will never go into children's services. He took a very dim view of the state that they were in that time. But that was in 1950, so one must assume that his ideas were based on what they'd been like by the National Health Service, which leads me into asking really what had happened between 1950 and when you went in. Do you think they had become worthwhile? Because he certainly had them written off in his view.
Oh no, they were very good. I suppose I don't know what they were like in the rest of the country. The hospital service, the hospital paediatric service.
The welfare services in the lot.
Well, I think I'd need to talk about them as two separate services, because they functioned as two separate services. The hospital paediatric service, to my mind, was excellent. Neonatal paediatrics was emerging. That infants were surviving. People were researching, and it was getting better, because there was a problem initially of infants surviving severely disabled. But even that was beginning to improve, with the neonatologists beginning to be able to assess which babies were likely to be severely damaged and therefore not striving so hard with those. And very, very disciplined auditing of both the obstetric and the paediatric components of neonatal services. Within the hospital, yourself and Bill up there on the top floor, you were researching in the guts, and that was new. I remember bringing my baby to you for a Crosby capsule biopsy at one point. Bill working away, both of you young, bringing an academic slant to it. Jim Farker downstairs, John Forfer. Trying to think, the surgeons were there, Freddie Robarts, Bill, Willie Bissett, and the plastic people, Mr. Batchelor. So it was. I was impressed by all that. The Community Child Health Service, which was the old Public Health Service, was beginning to be in transition. But what it was like when I first became involved was exactly what I had not wanted to be involved with in the Public Health Service. Routine examinations of well children that were sort of purposeless, unconnected to either the general practice service or the paediatric service, just seemed to me ridiculous. And some of the I'll say women, because they were all women apart from one. Some of the women were absolutely excellent clinicians. Some of them weren't. And it wasn't age related. It was whether they actually could understand the whole child. But what we did, and initially, was to develop, and we were very lucky because John Forfer, I think, was chair of, what was it called at the time, the paediatrics. It wasn't the college. Paediatric Society? BPA, yeah. And he was in London, and he was wanting to see this cadre of doctors better trained. And we also had Alistair Donald in primary care, who was chairman of the new College of GPs in London. And he too wanted to see better training in the community, in the care of children in the community. So we had a fantastic opportunity in Edinburgh to develop training in this, what is now known as community paediatrics. It was being called community paediatrics. And Jim Farker and John Forfer set up the School of Community Paediatrics, which I was involved in helping to ensure that that happened, developed training programs. Alistair got a special program for GPs to come and do 6 months to sort of have a cadre of GPs who'd had extra training. Then we were able to introduce a sort of, I don't think it was called senior registrar and senior registrar training. We had to use the old community child health doctor terminology initially, but we managed to change it. And Edinburgh really led the way in developing training in community paediatrics. And we were lucky. We had some 3 or 4 extremely able, they were again women, women doctors, because the women doctors were now beginning to work. They were beginning to work right through having small children. There were beginning to be arrangements to work part-time. There were beginning to be arrangements to have your children looked after. So it was beginning to be possible for the bright young women to stay in clinical medicine. And my experience from having done medical manpower, because we actually officially launched in Lothian Health Board a job share scheme. But my experience of that and knowledge of how training programs worked made it possible for me to sort of help find practical ways in which these bright young women could fulfill the proper and rigorous training requirements of the college, the Physicians' College at the time, and get a proper training in community paediatrics so that they would be respected by and be properly eligible for consultant posts and respected by the hospital colleagues. It wasn't always comfortable, but I think most of them have proved that...
not comfortable?
Well, there were bumpy times. There were bumpy times when the GPs still couldn't see that this, another doctor seeing their children in a community setting being acceptable. And some of the hospital paediatricians, I think, found some of the community paediatricians, they needed to prove themselves. And I like to think that they have proved themselves.
What do we say is from the point of view of the service developing, what was being provided, developing at that time? I'm quite interested in the view of the public view of these services. One of the reasons being that it's reading about things in the past that going back far enough to John Bale and people like that, when they set up their ideas. They were at that time very ambitious and very sound, but they pretty well came to nothing, or if not nothing, less than they should have been because of resistance from the families themselves. That, for example, the original scheme for examining these children had to be cut down because families said this was an invasion of privacy and so on, and there was resistance again to things like immunisation. That was, in the 30s, 20s. Do you think that had changed? I mean, when you were organising these services, you can quite see that was an ambitious and a very, successful arrangement from that side of it. But how about the patient side of it and the acceptance and the readiness of the public for that?
Well, a couple of things. I think it had changed enormously, and I suspect it was because we're now into the 1980s. The public had had a national health service for 30, 40 years, and expected to have a breadth of service. When I was doing the rubella vaccine trials, obviously I was looking at public responses to a vaccine program in much more detail, and I think we had 2%, 3% refusals. It was tiny, absolutely minuscule. We were blood testing all the girls first and only immunising those who were found to be seronegative. But it was literally 2 or 3% who refused the blood test to see whether their children needed it, and then nobody refused it if they were found to need it, because the logic was your daughter is at risk. Except for one school, the Rudolf Steiner school has the school doesn't approve of vaccination in general. So the children there were given their results, and it was left to the parents to decide whether they would or wouldn't go to their own doctor for a GP. But that was a handful of children out of the whole cohort of children in Edinburgh.
So was this sort of resistance to immunisation that we hear about now, do you think this is a regression for some reason?
Yes, because at the time I came into this thing called community medicine in the early 70s, that was the pertussis, the drop-off in the pertussis immunisation stimulated by Gordon Stewart. Now, that happened. It fell from something like 80%, wasn't it? It was well over 80, and then it dropped down to about 30 and 40. And I think that the drop-off was not only the adverse publicity, but that the public health service at that time was in chaos because of the reorganisation in 1974. There was nobody there to stand up and persuade people that it was okay, or that not being given pertussis ran the risk of whooping cough, which we saw come back later on. So by the 1980s, something else had changed. By and large, children were being immunised by their GPs. So they were getting a primary care service from their GPs, children. So the old child welfare service, the child welfare clinics, were less. They weren't doing, not as many children were attending because the GPs were doing the vaccine bit. Child's preschool surveillance was not as structured and evidence-based as it now is. So it wasn't pushed and it wasn't monitored, and so I don't think we knew even how many children were being covered. And the school health service, as I say, continued to see all children and not a selective group of the children who needed it. So that was all part of what we changed as well, saying that a child who's had routine surveillance in a evidence-based programme from its GP, there's absolutely no need for that child to be given another full medical when they come to school, so long as there's a sharing of records and sharing of information. So the school health service can concentrate on providing what is effectively an occupational health service for children with special needs. It can be the service that acts as the paediatric service in the community for children with long-term disabilities of various sorts, or children with very difficult behaviour problems, or children with profound and complex social needs.
Right. In a way that has a slight disadvantage, isn't it? Because the school population is a very nice, documented, solid population for any kind of reviews or
very
studies.
Tidy, yes.
You've got them all on tap there.
Yes, you can still do that. I mean, there are still research projects that catch all children, and a lot of new vaccines are almost all introduced through the school system because it's the most efficient way of getting a new vaccine into a large number of children.
But is there somebody now looking and say what the incidence of dental caries is? And
yes,
so,
yes,
no,
the dentist is still doing that.
Right.
And the nurses are still weighing and measuring them.
Right.
So that those anthropomorphic, that data is still...
Because that was one of the things that was abandoned in the 20s and 30s, so that was,
right.
that was new to get that back in. So what you're suggesting is not suggesting, is that there was a cooperation between the GPs in some matters relating then to them. Did that work smoothly?
No.
GPs?
No. No.
That was an invitation to tell us.
The GPs, my daughter's now a GP, and I'm beginning to be more understanding of general practitioners. They just are hugely diverse in how they operate. Some are extremely good at working in partnership with, whether it's hospital consultants and giving good information across. Similarly with the community paediatricians, working in partnership, and I'll do this bit, can you do that bit, and particularly for children, for families where there is a child or children with special problems. Others are still, I don't think they're still writing please see. I think general practice has improved over the last 30 years. I think that they're mostly better able to work with others. But it was bumpy to start with. And certainly there were in the 80s GPs who on no account were going to pass any clinical information to one of these school doctors. And just to go back to your question about what did families think, I found that families were absolutely shocked to learn that the school doctor didn't know this bit of information about their child in the health service, because they thought the health service was all one service. So it was really the reverse of what the GPs were anticipating, that by and large the parents expected information to be shared.
This was something I found very difficult, that patients would talk about you, me, in a collective sense.
Way, yes.
That
yes.
I wasn't me, I was a collective
you are.
thing.
Yes, yes.
And that embraced every part of the health service.
Yes.
Which was very much a patient attitude for things. But then you think that these services, were valued then by the patients by and large.
Yes. In fact, as we were changing the school health service, which was partly because it needed to change, but it was also partly because we were going through major financial problems at the time and having to reduce the numbers of doctors around. So for all sorts of reasons, the poor community child health service was seen as a soft target by both the hospital doctors and the GPs. But as it turned out, it probably wasn't a disaster that happened, because it actually became more of a stimulus to change.
Could you explain a little bit about that financial pressure? I mean, when was those?
Well, until about 1984 or so, 83, 84, all the time I had been working in this administrative side of the health service, we had our allocation for Lothian each year plus 2% or plus 2.5% or something. So there was always a real, that was over and above inflation, increase in the allocation until about 1983 or 4. And initially it just stopped. There was no increase. We got inflation correction, but we didn't get any extra. And then, year after year, we started getting what was called negative growth. We started getting cuts. They had all sorts of fancy names, but the commonest one that settled down was called cash releasing cost improvements, which meant that you had to change things and release cash in the process. I mean, the government's still doing it in terms of calling it modernising and things. They use these words. So what happened from about 1984 is first no growth for a year or 2 years, and then actual cuts in the allocation. And initially it was possible to squeeze efficiency savings out. But there came a point where it had been squeezed and squeezed and squeezed, so that by, this efficiency saving, the child health doctors were seen as a fairly soft one for doing some cash releasing cost improvements. They were an early one. But after I had left my specific involvement with the Children's Service, I'd by then become what's called CAMO, Chief Administrative Medical Officer, later Director of Public Health. The year-on-year savings were beginning to really be almost impossible to find without impacting on the service. And in 1991, what happened in Lothian Health Board was that it collectively, all the hospitals collectively, were grossly overspent. And not only overspent, but nobody quite knew how overspent. So the whole system was in a bit of chaos. And we had to do some fairly radical changes at that time, which were fairly uncomfortable. I mean, there was a big package of hospital and ward closures. I had to save £1 million out of the medical staff budget, which is a lot of posts. That was in 1990. And so the transitions of the community child health service contributed again some more savings to that. And so that was why we ended up with a different type of service afterwards.
So looking back, I mean, were there really material losses from the service, do you think, due to that squeeze?
It was incredibly uncomfortable time for everyone. Anger, service changes that weren't were difficult to understand. In practice, some of them, in retrospect, may have turned out to be for the best. That they were changes that were going to happen anyway. I mean, an example, I suppose, was the closure of the paediatric unit at the Western. I was particularly sad about that because I had done paediatrics down at the Western. But there were so relatively few children coming into hospital at that time. We had over-provision of hospital beds. The staff in the unit at the Western were really not getting as much experience as they needed to be maintaining it as an acute paediatric service. So it probably was the right thing that it closed, and it almost certainly would have closed at some point anyway for clinical reasons. And this discipline of having to make service changes just may have brought it forward. What was fascinating, and we were incredibly lucky, although this 12 or 13 million, I can't remember what it was exactly, total saving had to be achieved, the area medical committee, instead of what it might have done and what I'm sure it would have done in many other places, saying a plague on you to the administration, what a cock-up you've made of this whole thing, how dare you need to go, a very angry response. There was an angry response, but the area medical committee said, well, if £13 million worth of cost in this health service has to come out, we are going to take a very active part in determining what that should be, so that it is not just the easy soft targets that the administrators think that they can take out, but it should be done on the most appropriate clinical grounds. And the clinicians were fantastically helpful in terms of identifying such things as maybe the time's come for the paediatrics at the Western and obstetrics at the Western to close.
I think we should. Could we stop?
Yes,
For a break?
yes.
Before we move on to talking about your more senior posts later on, could we just at this point say something about how you had managed personally with family, children growing up, looking back over that whole period? I mean, difficult?
Very.
Less difficult? Memories of it?
Right. It was difficult. It was hard work. We were incredibly lucky because the university had a nursery which it had established, I think, just shortly before our two were at the stage of needing to go to a nursery. And it took babies from 6 weeks. So we used that for the preschool period. And it ran all through the year. It only had Christmas holidays. I think it started about 8:30 in the morning and it went through till 6. So it was an amazing service. And I couldn't have done what I did without it. There are now, 2004, lots of such nurseries, but it was the only one of its kind at the time. Now, we used it for both of them. Our second child started at 6 weeks, but it hadn't been there for our first child. What I did with him, when I first went back to work, I took him with me. I took him to the lab. I kept a pram there on the balcony of the virus lab. And he spent most of his day asleep, but I was still feeding him. So I fed him. There was a big sort of ante-room to the ladies' toilet where people changed. And we used to go in there and I fed him and looked after him. Then he got back in his pram and I worked away. And 2 stories from that. One was that I thought that only the people in the lab knew. But one day there was a visitation from the Hospital Board of Management. And I thought, oh, goodness me. Oh dear, what are we going to do? And what I heard was Mr. Wellstead, the board secretary, as he opened the laboratory doors, the big swing doors, said to all these ladies and gentlemen from the Board of Management, we must all go and see Dr. Zealley's baby. So they had obviously known all along, but I hadn't asked, and therefore they hadn't had to say no.
Right.
They just acknowledged it. But he was, by that stage, about 6 months, and I was at the stage of looking for a baby minder to look after him, which we found just near to the city hospital, which is where the lab was. And so he went to a marvellous baby minder lady who had been a washer-up in the lab. She was just a wonderful, wonderful, one of these born mothers, grannies, who her house was always full of children. And he was spoilt rotten. So he was there till the other one was born, and then both of them went to the university nursery. So that was preschool. And then that all worked because it was continuous throughout the year and things. Then children go to school, and you actually find out that children of school age are much more difficult to make arrangements for, because they go to school in the morning, they don't go to school in the afternoon, You have to have arrangements for the afternoon, you have to have arrangements for the holiday, you have to have emergency arrangements for when they're off school, if they're unwell. So that became more difficult, but in fact, Auntie Molly, who was this baby minder, came and looked after them at our house, and that all worked well. And then she grew older and wasn't able, but by that stage they were getting older. So I had somebody who came to the house for the time when they came home from school, and it's all worked out. But ironically, Ian, when he went to university, one of his buddies at university turned out to have a father who had worked in the virus lab at the same time as when he had been there as a baby. So Ian constantly rags me about how I brought him up in an incubator and how dare I, and I risked his life and all of these things. But so that sort of is a story from the time he was there in the lab. But it wasn't easy. It still isn't easy for families. This very week I'm looking after my younger granddaughter, whose mum is a part-time GP and whose dad's working in hospital medicine, because she's got chickenpox, and the baby minder that she goes to looks after a little boy who's on treatment for leukemia. So she can't go to the usual baby minder, which is fine, and it's lovely for us and we're glad to do it. Mm-hmm. But that happens, and it falls to the parents, but it still tends to fall to the mother parent rather than the father parent, to have to pull out stops and do something different.
The fact that your husband was in medicine too might have helped too.
It helps, yes. Yes, he was helpful. I mean, I just had an unbelievably demanding job. Although it wasn't clinical, the hours were unreal, the demands on it were unreal. And Kirsty, she went through the same school from P1 to S2, second year sixth form. And at the end of her whole career, she got a special sheet saying that she had had no day's sickness in her whole school career, because she wasn't allowed to be sick. I mean, we were lucky; they were actually both pretty fit children, but she wouldn't have been allowed to be sick.
So, what stage were they at when you became McCae, roughly?
1988.
Sort of independent by then.
Yes. Golly. Did I get disorientated? Yeah, they were at university. Mm-hmm. They were sort of both halfway through university.
Could you tell me about your move into being CAMO? I mean, how did that appointment come about? I mean, was it?
Well, it came about sooner than it might have done, because my predecessor, Colin Brough, found that he just couldn't tolerate the change to the management arrangements that happened in 1986, which was when general management and general managers were introduced to the health service in Scotland. And previously, the senior management arrangement for a health board replicated at different levels in the service was for a team leadership of a doctor, a nurse, an administrator and a finance officer. They were called the executive team, I think it was called. And what tended to happen was that one of those four people tended to take a leadership role. And when that happened, and the other three were comfortable with it, there was some quite good, there was some quite effective management. But what happened more often, this is around the UK, what happened more often was that one would tend to take a leadership role and the others resented it, and there was conflict within a management team. So that particular management structure that was introduced in 1974 wasn't the world's most effective one. And Mrs. Thatcher, who was Prime Minister at the time, asked Roy Griffiths of Sainsbury's to look at the health service and make recommendations. And he for the management of it, and he recommended what, and I put it in quotes, the introduction of general management, close quotes. And talking to him on a one-to-one basis afterwards, what he meant was, just clarify which of these people is the lead manager so that it's quite clear. But in practice what happened was a whole new cadre of people called general managers were imposed on the service, or were introduced to the service. And by and large, they tended to be the administrators who applied for these posts. So there was a feeling that the administrators have won in a battle, mostly with the doctors, and occasionally with the finance director, the finance officers. Anyway, what happened in Lothian was that a guy, the person who had been the secretary, the administrator of Lothian Health Board, reached retirement age and he opted out. And within Lothian, a general manager came up from the south, threw his weight around a bit, and my predecessor, who had been camo, he'd been, I don't know, about 6 years at the time. It was uncomfortable for him to have this guy come in, rule the roost, where previously, as the Chief Administrative Medical Officer within Lothian, he had tended to fulfil the leadership role, lead the planning function, and he stuck it out for 2 years with this general manager, and couldn't go on, didn't want to go on, and he'd reached a stage where he was able to take earlier retirement and go. So the post came up. I didn't like the general management. I didn't like this, to my mind, demoting of medicine. But I recognised that it was what it was, it was what was happening, and the thing was to get stuck in there and try and make the best of it. So I was prepared to go along with it and applied, and it wasn't entirely comfortable. It was supremely irritating at times to have people whose knowledge base of the front line of the service, the real challenges of the service, was theoretical rather than a real practical understanding. But one of my functions was to try to educate them, to try and help them to see why some particular proposals would just not work, and how best to implement other ones that would work but needed to be introduced in an appropriate way. So instead of doing what I really would have preferred to spend most of my time in that job doing, namely working on the preventive side and helping to improve health and preventive medicine, I found myself doing much more of sort of firefighting, ensuring that worse things didn't happen. And it was actually during this particular general manager's time that the big financial problems happened, because he couldn't do it. He was out of his depth. He'd just lost the plot and didn't know what was happening. So he actually eventually went, and the chairman, who hadn't identified that the general manager couldn't do it. So then we had another one, a new chairman and a new general manager, and after about 4 pretty uncomfortable years, it became clear that that general manager couldn't manage either. And he went. The chairman stayed on with that one. He was able enough, but he was okay. He was maybe more, he came from industry, was maybe better able than I was to see that actually some changes were needed. but it wasn't a comfortable 10 years or so, and we kept having restructurings, reorganisations, enormous amount of energy, time spent on reorganising the service as though its organisational structure was what was important, whereas in fact what was important was ensuring that it worked as a coherent whole, and that the interaction between the front line and patients was ideal.
And was the major pressure point finance at that time? Or was it policy priorities? Finance,
I think, because we were still having these year-on-year cash releasing cost improvements. The tightness of finance made it really very difficult, yeah.
But it's probably a difficult question because this was a particularly difficult time, but say a little about what being a camel was.
Oh, right. Well, the title, isn't it awful? Chief Administrative Medical Officer. It emerged from the former Regional Hospital Board senior administrative medical officers. That was pre-1974. And then they had principal medical officers and senior medical officers. So this terminology, medical officer, was very... the people who'd been in administrative medicine a long time were very comfortable with it. I found it uncomfortable. And I think they just used the word chief instead of senior to indicate a change. It was always a slightly ambiguous role because I was the chief medical advisor to the health board, to the board. I didn't have a formal relationship to the clinicians, either the general practitioners, who of course are independent contractors, or to the hospital consultants. But I was responsible if hospital consultants needed disciplining. That was my function, to do any disciplining, or investigation and things like that. So, in theory, it was an hierarchical role vis-a-vis consultants. But it wasn't actual. I mean, I couldn't go round, it would have been, I'd have had my legs chopped off if I'd gone around telling consultants that I was their boss and what they were to do. And I certainly never worked like that. I hope nobody ever thought I worked like that. But by the same token, because of this formal disciplinary role on behalf of the board, certainly my husband used to joke that I was his boss, which wasn't the case. But what we did do, and I think we did very successfully in Lothian, was encourage groups of consultants to work together in divisions. Do you remember divisions and hospital management committees? And function with usually elected leaders from amongst their own group, of paediatrics, of medicine, of surgery, of obstetrics, or whatever. And I like to think that in Lothian, that both my predecessors, Ian Campbell and then Colin Brough, and myself all sustained and helped that to happen. It didn't happen everywhere. There were not as effective. The clinicians didn't work effectively together in all the health board areas. And I think that was something that we did try to achieve. And I certainly saw that as a function of my way of fulfilling my role as chief medical advisor, was to support and encourage the clinicians to develop advice, strong clinical advice, and then take that and support it into the board.
And did a CAMO at that time influence policy?
Oh yes. I was talking about the recovery package for the savings, and the recovery package was almost entirely my recommendation. But my recommendation was that which had been built up collectively through the Area Medical Committee. Obviously, I worked with the various divisions and groups that were pulling forward proposals, to ensure that they understood that if they couldn't come up with effective proposals, somebody else would, and they might be much less effective. So it's a bit of a reality check. But also providing information, analyses of throughputs and workloads and things like that. Our team produced that so that the clinicians had the data with which to bring forward reasonable recommendations.
One of the things that interests me in that is in regard to policy. And did one region board evolve its own sort of list of priorities, for example, which might not have been shared by others? Because if you've got pressure and having to make choices,
yes,
then clearly somewhere in your mind you would have to have a scale of priorities,
yes,
as to which services were
yes,
more vital than others.
Yes, we did. And implementing some of those policy changes were not always easy. I mean, a good example was the introduction of geriatric medicine, whose resources came almost entirely from the general medicine world, both in terms of clinician appointments, that it would be not taken for granted that physician X coming to retirement would be replaced by a physician, but might be replaced by a geriatrician. And the physicians fought quite hard against that, particularly the physicians in the Royal.
So I'm questioning that. Was there not a phase, at least, when there was tuberculosis, and from that point, are you counting?
Yes,
had that passed?
That was just about past before
right.
I came in. But yes, you're right. The initial geriatric physicians came from a tuberculosis background, both literally, in terms of they had been, Ian Milne, Jimmy Williamson, had been chest physicians, tuberculosis physicians, and as the number of tuberculosis patients diminished, they
because very often the accommodation came from the same stores.
It did indeed. It did indeed. But by the time I came in, the development of geriatric medicine was continuing, and they'd run out of that resource, and it was coming out of general physician, mainly because it was, general medicine wards were full of very elderly people with multiple needs that the specialist, because there was, of course, it's the same time as growing specialties within medicine, that the specialty physicians weren't necessarily best able to look after elderly people with multiple pathology, whereas the geriatricians were. So it was, on the one hand, I think the general physicians or the specialist physicians were glad to have these older complex patients removed, but they didn't actually want the facilities removed as well. But that probably is one of a very big change that happened. The complete restructuring of the hospital service in Edinburgh happened during my period. I think I counted up, we've closed 17 hospitals in the period I was both a consultant and CAMO. There's a lot of hospitals. Built the new ones, the new St John's, the new Royal, and effectively rebuilding of the Western. And the planning for that started late 60s, for that whole restructuring of hospital provision in Edinburgh. So yes, the medical side was very, very much involved. In terms of another service that I saw during my period was the introduction of a complete new service for HIV. New disease, major problem in Edinburgh, rather than Lothian overall, but major problem in Edinburgh, impacting right across right across the board. So that had to be introduced as well.
I'm curious about the matter of priorities. I mean, could you identify and say, you know, in the Lothians, these are our priorities, and we can detect a difference, let's say, from another region in any way? Or was there sort of pressure on a certain degree of conformity between regions?
Initially, when I first came in about 1974, it was clear that Lothian was well ahead. Geriatrics at that time was the priority to be developed. Later on, it became we were given priorities from the Scottish office. Now I don't know whether we were given geriatrics as a specialty, as a priority from the Scottish office. I suspect probably we were, but it was being developed more actively in Lothian than in other places. I think that certainly was the case. Mental health was, the SHAPE priorities, mental health and geriatrics, were definitely given as a national priority.
And in this, you know, to particular interest of mine, in that your priorities, they were coming from the Scottish office.
Yeah.
Was there any, do you think that they in turn were given priorities by way of Westminster, or did they have a certain
national
amount of
priorities?
leeway?
They certainly had autonomy. The Scottish office has always had a degree of autonomy from the English Minister of Secretary of State for Health. I suspect, I don't know this, but I suspect that the similar priorities will have been identified in England because they were similar needs.
Right.
Growing older population. Paediatrics wasn't a specialty because the number of children was going down, and the resource available within paediatrics per child was effectively increasing, but within a fixed envelope, apart from this bit in the community child health services that I talked about earlier.
It's just in the past, the Scottish office was able to have quite big differences. For example, difference in policy with in the old days with the emergency medical service and what they did with the Clyde Valley experiment and all of these things, which were entirely Scottish initiatives. And I was just, since I've been interested in them in the past, I wondered to what extent that kind of autonomy persisted, because pressure from the Treasury, of course, must have ensured a degree of conformity.
Yes, but no, there were organisational differences. It's very interesting. I can't remember exactly when, but in 1974, the whole UK was sort of given a fairly similar structure. It was a big reorganisation of pulling the hospital administration and the public health and the GPs all in, and it was UK-wide. And both north and south of the border, there were area health boards and districts. There was the area health boards were strategic, districts were operational. That was the arrangement. And both north and south of the border continued like that until I think it was about 1982 or something. And that was the first of the reorganisations, that it was clear it wasn't working quite right. Mm-hmm. And the real reason it wasn't working quite right is that actually within healthcare you can't entirely separate strategic and operational. The strategists have to really understand operational matters, and the operational people have to feed into strategic change. But managers don't understand that. They think in management theory, and you have strategy and you have operational. Anyway, there was to be a change. But interestingly, in Scotland, we disbanded districts. In England, they disbanded area. So there was a separation of the ways at that time. And so England sort of had far more health authorities, they started calling them then instead of health boards, because they'd taken all their districts to become autonomous health authorities whereas we stuck with the bigger strategic group. And it's fascinating for me to see this current restructuring north and south of the border, which is hugely different. The Scottish NHS calling itself the NHS in Scotland, no, NHS Scotland, a logo for NHS Scotland. Every health board has to use the same logo. It's in management speak, it's called branding. But so they all use the NHS in the same font, and it's NHS Lothian, NHS Glasgow, NHS Fife, and then the overarching one is NHS Scotland. So very clear signal that the NHS is one family, that it works as a cohesive whole. Whereas in England, they've gone down to things called primary care trusts, so the general practice bit is hived off and hospitals are going off autonomously, sort of almost pre-NHS. Not just pre-1974, but pre-NHS, going off autonomously and raising their own capital in the marketplace and things like that.
And that, of course, has got its origins and history, isn't it? I mean, the Scottish system has always been centred on the university
and
centres.
a coherent whole, yes.
And
yes.
That, since the university set up, was the core of the thing. Everything followed,
yes.
which certainly wasn't the case in England.
And I anticipate that in Scotland we may go back to rather bigger strategic groups, possibly to the 5 that we had in 1974 when I came in. The regions. There's certainly a lot of encouragement from the centre for the health boards in South East Scotland to work together, the health boards in the west of Scotland to work together. You're absolutely right, around the university catchment zones.
You became the executive director.
Yes.
So, if we talk about that, is that essentially the same thing as the camel, or was there a material difference, distinct from a title difference?
It was one of the reorganisations. Through the 1980s and continuing, there seemed to have been reorganisations of the management structure about every 2 years. And one of them, and I can't remember exactly when, but it probably about 1996 or so, one of them introduced the concept that the lead officers of the health board, the doctor and lead officers within the health board would be appointed as executive directors alongside non-executive directors, like business, like the commercial world. Whereas previously we had been staff and the health board members had been members. And we were different, we were their employees.
Right.
Now, that particular reorganisation made it that the general manager changed his terminology and became called a chief executive, and he was ex officio going to be a director, and there could be 3 other directors, and it varied from board to board which 3 of the senior staff were appointed. Mostly the camo was appointed, but not always. And the difference was that as well as being appointed to my job, I then got appointed as a director by the Secretary of State. So I sort of had a double role. And there were moments when I smiled to myself and thought, golly, if I really get very, very distressed, and I almost did in relation to the introduction of trusts about what's happening, I can resign from being an executive director, but I can still stay in my job as camo.
So it wasn't in fact simply a title change.
It wasn't. No, it actually, and in 1 or 2 places, the camo was not appointed as an executive director because the chief executive had it in for them. Quite uncomfortable when that happened.
What happened to chief nursing officers and all of this? Did they?
chief nursing officers disappeared. The chief area nursing officers disappeared. It's terrible. I actually can't remember which of the organisations.
Why was that?
They mostly hadn't made a major contribution at in the strategic role. Very, very important in the subsidiary management, where it was managing large groups of nursing staff, developing nursing staff. But they hadn't mostly played a big role at a national level, at a board level.
So that was really, I
think it was just reflecting reality,
it was
to be
a
honest.
sort of pragmatic decision rather than a theoretical one.
Yes, but every board now has to have a nursing officer. I don't know whether they're necessarily executive directors, but they do necessarily have to have a nursing officer. No, they have to have a director of nursing. All health boards. It's a given.
Right. And so how long were you executive director then?
Well, I stayed as CAMO because CAMO is the terminology that's in the legislation for certain things to do with the public's health. We reintroduced the terminology Director of Public Health because our specialty decided, quite wisely I think, to change its name from community medicine, which nobody understood, to public health again. And we started calling ourselves Directors of Public Health, and that's now become an accepted terminology. So CAMO remained for the legislative role, but I gradually stopped using it. Director of Public Health, because that more clearly described what I was doing, what I was aiming to do, improve the public's health. And Executive Director, well, I was an Executive Director of Public Health, if you like. And I was that, I think it was probably about 4 years. I retired in 2000, and I can't remember when. I think it was 1996 or something, the Executive Director role came in.
And does this move back to recognising it as public health, you think, is a good move?
Yes, I do. I think the public health in the 60s and early 70s was not very impressive. But before that, I think it had a very proud history. I think the history of public health from about 1870 or so right through, I think actually is very impressive. When you think of the number of other disciplines that have emerged out of public health, health visitors, the veterinary service, the environmental health officers, the sanitary inspectors, social work emerged out of public health, health promotion. Now, they're all independent disciplines now, and collectively, the public's health requires all of them and many others to work together. But we now are sort of clear that we have three functions. We have, as public health doctors, we have health protection, which is a very traditional protecting of the public, which of course now goes into chemical hazards, nuclear waste, all sorts of things like that. Health improvement, which is about helping individuals to understand what makes them ill and how they can stay healthy, but also back again working with local authorities, other organisations, to say that what you do as a council actually impacts on the housing people live in, all the environmental structure within which people live. So that's a health improvement. And thirdly, planning and contributing to the planning and evolution of healthcare services so that they are appropriate to meet the needs of the pathology that's around at the time. In
this public health scheme, I can have no doubts about the value and how it would work, how, when you're working through institutions.
Mm-hmm.
What I'm interested in is working directly with the public, because that seems to me to be a very problematical area over the years. You know, sort of broadly calling it sort of health education.
Mm-hmm. Well, yes, in terms of one-to-one work with the public, as doctors, our main function is in relation to control of communicable infections. I mean, meningitis cases, it's our job to go in quickly and cope not with the clinical case, but with the contacts and things like that. And that remains, and case finding and tracking and finding this, helping the environmental health people to find the root cause of Legionella, Salmonella, E. coli, whatever it is. So that's our immediate public health interface with the public. In terms of health behaviour, I suppose the public health doctor's role tends to be primarily an epidemiological identification of what processes are happening, working with epidemiologists on, say, diet, and then working, absolutely you're right, through organisations to try to influence the food that's available to people and try to ensure that people understand, whether through one-to-one education, which would normally be through their GP or through their practice nurse or in that sort of setting. I mean, smoke stop clinics, for instance, are run in general practices mostly. And our job is to help ensure that those smoke stop clinics can happen. Okay, to encourage primary care to offer them, to ensure that the funding's there to do it. So you're absolutely right that the function is, and it's explicit, public health functions through the organised efforts of society. Using whatever structure happens to be the prevailing structure, organisational structure of the time.
So I watch all these thick comments on television about smoking and one thing to other, and hark back to the Cathcart report 1936, and one of the things that they were very firm on was that such campaigns were a waste of time.
Well, they work with the wrong people, that's the trouble. No, they do work, they track them and they work. I don't know if you're spotting, but at the moment the smoking campaigns are trying to raise awareness of the issue of passive smoking. Because the evidence that's beginning to emerge is that passive smoking is actually much more of a problem than we realised. It's not the relatively small number of lung cancer cases, it's actually the impact on cardiovascular disease, and places that have managed to achieve bans on smoking in public places, they've seen a step change in coronary deaths within a year or two. It's that quick. And so what's happening at the minute is quite a number of initiatives to try to raise public awareness of the danger of passive smoking.
In the last few minutes, I want to hark back to, hesitate to call it the feminist angle, but just because this is one of the tremendous changes that has taken place over your years in the profession, because women are no longer exceptional pressure, they're beginning to
dominate.
And that leads into other problems that I see it of staffing in the health service in the future. I mean, one hears of people sort of moving to the south into private practice, moving overseas in academic posts and so on. Do you take this kind of gloomy view of of the future of the staffing of the service in Scotland, particularly?
I'm not gloomy. I'm delighted to see that it's, that it is, women no longer have to make a choice, that they can choose, and that the structure even sort of bends over in their favour in terms of when they're in training, moving from place A to place B if a husband's job changes. Even that is beginning to be overcome. Sometimes, I think, slightly unfairly to the men, and I say that because my son-in-law is having to travel every day to Dundee because that was the only place where a specialty registrar post came up in his specialty, and Kirsty, his wife, is a GP here. So he's got this long journey, and apparently it's because all the specialty registrar posts in Edinburgh keep being taken up by girls whose husbands have come to work in the banks and things like that in Edinburgh. So I think there has to be a caution and a fairness, not necessarily equity, but a fairness. But recognising that the women will probably want to work less than whole time for a period, but not forever. It's 6 years, 10 years possibly, but they'll still have 20 or 30 years when they'll be back and comfortable working full time, given that the whole medical workforce is not being expected to work such long hours in the future. Rightly or wrongly, whatever one thinks about it, the consultants of today and tomorrow expect a different life than the consultants of yesterday in terms of the amount of time they're going to be giving to their profession, whether they're men or women. And that's an inevitable consequence of the introduction of a concept of working hours, which came 20 years ago to junior doctors, and it's just working its way through the system, as well as obviously the European directive on working hours, which is there as well.
Well, this isn't the last thing I was going to bring up. I mean, to what extent are we going to be drawn into European practices and standards and the European register of specialists and so on?
Well, we've got
we've
got a register now. We're still managing to maintain a rather longer and more disciplined, I think, training to get on the register. I don't know. I think we might move to a European one, but I don't think it'll matter. I think what we're doing nowadays is training. We're still recruiting the most able young people, girls and boys. They are amazing, these bright young people. And they are being trained at university now to go on learning forever. So that it won't just be the 4 years of their formal training programme that is their training. They'll be training in an ongoing way. And in fact, remaining on the register requires that they go on training. So I don't worry about that too much. And actually the working out of the women's part-timeness is all right. What is showing up, of course, is that the UK has fewer doctors overall than most other countries, and that is beginning to be addressed as well. So I would be optimistic.
That sounds like a very good optimistic note at which to end.
Okay.
I'll pass forward.